A stereotactic program. Are you prepared for it? How will you monitor it? Can you improve on it? These are questions that Standard Imaging can help you answer as we partner with you on your SRS SBRT program journey. Hi, I'm Andrea Zenz, Product Manager here at Standard Imaging. Today's webinar will address how a QA complete stereotactic solution can help you meet clinical goals, especially in terms of simplification and standardization that improves efficiency, patient safety, and clinician experience. As you well know, there are many guidelines, task group recommendation, codes of practice, regulations, and so on related to stereotactic programs. Since the AAPM RSS Medical Physics Practice Guideline 9A was developed to provide an appropriate minimum standards for LINAC-based SRS SBRT services, I figured that was a good foundation and sort of what I referenced in order to put this presentation together for you. Now, they say it a lot nicer than I usually do, so I'll say what they state. They note that the high dose per fraction and the critical importance of targeting accuracy, SRS SBRT services require a strong commitment by the radiation oncology program and the facility to provide the appropriate resources. Both the clinical team and the institution's administration must understand their roles and commitments in this regard prior to implementing SRS SBRT services. Resource commitments are vital to a program to meet clinical goals while limiting risk and emphasizing patient care and safety. They include enough properly trained and certified personnel, such as radiation oncologists, medical physicists, dosimetrists, and therapists, so as to provide enough time for all of them to safely perform their work. Appropriate equipment to support the treatment process, imaging, treatment planning, LINAC, SGRT, and IGRT systems, as well as the appropriate instruments, QA devices, and software to ensure proper safety and functioning of said equipment. Clear operating procedures with delineation of duties is, of course, required. And certainly a safety culture rooted in transparency and process analysis. So you, the lucky physicist, I'm assuming I'm talking to a fair number of physicists here today. As a qualified medical physicist, you play absolutely a vital role in so many of these resource recommendations. And PPG 9A goes on to specifically outline 10 key responsibilities of the qualified medical physicist. I've only listed a few here, since I'll basically be focusing on these during the rest of the webinar. Since these responsibilities are directly linked to many departmental goals like patient safety, patient throughput, and clinician experience, it is our job as your partner in all things QA to help you meet these goals safely, efficiently, and effectively. In other words, help you simplify to standardize. But also help you prepare and monitor the various aspects of your treatment delivery system as described in the section on simulation planning and treatment, particularly as it pertains to mechanical accuracy, localization, IGRT, and SGRT. So let's delve into it, shall we? The first recommendation in the equipment list, in the instrumentation list, is to have redundant radiation detectors suitable for small fields. Sounds simple, yet we know that dose delivery to small fields poses a variety of challenges, such as physical size issues. We're talking about 4 to 40 millimeters in size. So how is your field size defined? Is it JAWS or full width half max? What is the decreased output in alignment? A small misalignment equals a large geometric and dosimetric miss. Scatter from primary collimator and flattening filter is reduced at small fields, but small enough fields are also reduced direct beam fluence. Equilibrium conditions, lateral scattering, distance equal to or greater than the range of electrons. What are the practical implications of this? You may start to lose lateral equilibrium when beam width is less than 2 times Dmax. Higher energies lose beam plateau sooner. Detector positioning, perturbation, etc., come into play sooner for higher energies. Important to characterize profiles, not just output factors. So once you have an understanding, oops, sorry for that, went too fast. So once you have an understanding of small field challenges, the next question is how do detectors impact your measurements? For instance, detector size and shape. Volume averaging effects are of concern. So need to ask what is the field profile versus the detector spot size. Also, how accurately can you determine beam penumbra? Consistent and accurate position of the detector can impact your measurement. This is an important consideration when choosing a stereotactic phantom, and here we're going to mainly focus on our Lucy EA phantom today. Do your features provide solid benefits to the user? Perturbation of the beam, fluence is perturbed at the point of measurement, so you ask yourself these questions. How large is the air cavity of my ion chamber? For diodes, is there a built-in compensation, or how does response vary with energy? There are published corrections sometimes available. To use those, you must match the published conditions. Signal, keep in mind that for ion chambers, the signal is proportional to collecting volume. Signal to noise ratio becomes more of a concern as signal decreases and small signals require an appropriately sensitive electrometer. Signal to noise ratio can be impacted by leakage, proper electrometer warm-up, or triaxial cable effects, both for the chamber and extension cables. It is important to match signal strength to the proper electrometer range. Accuracy. Need to answer these questions about the detectors you want to use for small field measurements. Does it have energy dependence issues? Does it have angular dependence issues? And what are the implications of different orientations? Are there dose rate or dose per pulse dependencies? What else am I maybe forgetting in my list here? Lots and lots and lots of things you physicists need to consider. Fortunately for you, one of Standard Imaging's foundational strengths is that of our QA complete and our complete stereotactic solution is that we have the best detectors available to solve these small field measurement challenges, including our diodes, which are unshielded and with a 1 millimeter spot size. 2 orientations, vertical or horizontal, either for scanning or in a stack of virtual water, for example, you'd need the horizontal. We also have the only reference class micropoint ion chamber on the market, which is the A26 up here, which has a spherical volume, a spot size of 4.3 millimeters. It's made entirely of low Z materials so that you have predictable response curve. So it's like using a Farmer chamber, but for your small fields. And last but certainly not least, I want to talk about our X-ray and W2 scintillator. Excuse me. It has a 1 by 1 millimeter resolution detector, and it has a KQ equal to 1, the only detector of any type of resolution like this with a KQ of 1. I have had physicists actually state to me on multiple occasions that they've come to realize that there's no way their SRS program is complete without the W2. As per the, again, back to MPPG 9A instrumentation guidelines, you will also need a high quality reference class electrometer that is stable and calibratable, as I also mentioned in the ion chamber considerations or detector considerations. Whether it is arranged to match with the signal of your detector, its warm-up time, and the number of channels, these are also important considerations when you select your electrometer. Last but definitely not least, Picking something with a good warranty is important, since I really feel that with electrometers, this says a whole lot about how dependable you can expect the electrometer to be. So here I'm showing our Max 4000 Plus electrometer, which is a single channel, very robust, reliable, repeatable electrometer. It is a real workhorse. It's definitely reference class. And then we have our Supermax electrometer, which is also a reference class electrometer with the advantages of a touchscreen display with intuitive navigation. It has 2 channels, so it's a dual channel electrometer with independent bias settings. And it has only a 1-minute warm-up time, which, again, nice and efficient for your QA program. So not listed as part of the instrumentation list, but definitely necessary for commissioning and continued monitoring of your small fields, you'll need a 3D water scanning system and potentially a 1D tank as well. All the detectors I mentioned, including the W2, are waterproof, so can easily be used in a water tank system, such as our DoseView 1D here for TG51 and TRS 398 protocols, or our DoseView 3D. Both water tanks use the same DoseView software, which we've been told is the easiest, most straightforward, and most intuitive software available for 3D tanks. We've added DoseView 1D to that same DoseView software so that you can have point measurement functionality as you scan your PDI curve. You can convert the dose and then drive the detector to the appropriate reference point for your electron beam measurements. For instance, all of this using the same program interface. Plus, if you have our 3D tank, you don't have to relearn the software when it comes time for your annuals or for commissioning a new machine. Now back to our instrumentation list, and it's a recommendation that you have appropriate E2E phantom or phantoms for the scope of your stereotactic services offered. Here too, we have options for your consideration. We help you determine which of our Lucy Phantoms are the best fit for your clinic based on your imaging protocols and your workflow. We have for your consideration the Lucy EA, Easy Access Phantom, which I will delve into today. You also have the Lucy MR seen here in the middle, which is the only entirely MR visible, fully anthropomorphic phantom for stereotactic QA. And then you have our Lucy 3D QA Phantom, which is, of course, the original one that we had, and is the most comprehensive and customizable of the Phantoms within the Lucy family. So I'll go a little bit, like I said, more in depth about our Lucy EA, since that is our most recent release that includes some key features that make it simple and quick to use. So Lucy EA Phantom is a pseudo-anthropomorphic phantom made of virtual water that is designed to perform comprehensive quality assurance tests for stereotactic radiosurgery SRT procedures. The Phantom allows verification of treatment planning software calculations for volume measurements, distance measurements, and image transfer. Dosimetry verification is accomplished via components that accommodate ion chambers or other detectors and film. The Lucy EA Phantom, as you can see here, is a toolless modular phantom with a large insert cavity in the brain region. The standard Phantom includes the multi-target 3D film insert, as well as a multi-target Winston-Lutz insert, and then there is an optional orthogonal film insert. The Phantom includes an extracranial cavity for detector, ion chamber diode, or scintillator placement. One solid plug with an embedded target and one drilled plug for your detector of choice are included with the Phantom. The centroid of the detector's collecting volume is matched to the center of the target in the solid plug. Just also want to know that the multiple target 3D film insert has 4 spherical targets arranged sort of at the outer edges so that you're really great for single isocenter multiple targets, low density irregular shape. The multi-target Winston-Lutz insert has 5 embedded fiducials in it that you can perform Winston-Lutz tests on, one at isocenter or additional ones on the other ones. And the orthogonal film insert has 3 spherical targets along the z-axis of different sizes as well for your QA purposes. The Lucy's pseudo-anthropomorphic features include eye socket, nose, forehead, and chin, heterogeneities representing sinus and oral cavities, skull, vertebrae, and spinal cord aid in simple, accurate localization. The Phantom also contains a large sagittal film plane that bisects the vertebral structure, which is here. The Lucy EA is typically set up in an open mass system that allows easy access to the insert and chamber cavities while the Phantom is immobilized to ensure positional repeatability. Alternatively, the flat base of the Phantom simply allows you to do a direct setup on the treatment couch without requiring a stabilization fixture. The Lucy 3D QA Phantom easily fits in the SRS patient treatment workflow. By using the Phantom as the patient substitute, you can scan, plan, treat, then verify with minimal setup variation. And of course, for the verify, we're talking about end-to-end SRS QA, daily SGRT, OSMS, and IGRT QA, positioning, repositioning, daily 6-stuff QA with the optional 6-stuff shift plate, coincidence of radiation mechanical isocenter, daily and monthly radiation isocentricity test, Winston-Lutz test, using 1 or more of the 5 distinct targets, film plus ion chamber dosimetry with up to 6 targets, 6 distinct targets, plus an irregular, like I said, avoidance structure in the mix. Accomplishing so much with so few inserts, swappable in an open mass system, makes Lucy EA ideal for standardization across sites and machines. Here are some sample images of CT scan, TPS with the contours. Note how clearly visible bony anatomy is on these images for localization, and as are the targets and the low density ventricle here. Avoidance structure, again, so easily visible. And here is a film analysis of either 2 of the PTVs or 3 PTVs, just to give you an example. And this shows you position of the 4 targets within the multiple target film insert. And here's the extracranial placement, which is an extended and robust, very robust test of trying, the limits of your ability to do a single isocenter multiple target plan. So using the multiple target Winston-Lutz insert in the Lucy EA Phantom as well is a integrated way to perform the required radiation isocentricity beam alignment verification. We do offer other options, such as our Winston-Lutz pointer with 3D micrometer for extreme precision, as well as a simple Winston-Lutz cube. And you can automate the analysis using PIPS Pro or QA Pilot with PIPS Pro Autopilot to keep it simple and efficient. Before moving on, I just want to take a quick moment to summarize how well our detectors with electrometer and the Lucy EA how excellent a basis they are for an efficient QA program, as they are used during commissioning and afterwards for monitoring the SRS program. What is easy to train is easy to maintain. What is sufficient is also efficient. What is reliable and repeatable is also robust, so you can simplify to standardize across your Linux and hospital network. As we strive for more efficiency, transparency, and risk management, especially when it comes to an SRS program, it is important to track trends so you can easily notice when things change. So since I think we are all generally interested in improving on what we do today so that we can be better tomorrow, a QA management software program is tremendously useful. QA Pilot with PIPS Pro Autopilot takes your SRS QA program to the next level with automation, customization, and oversight tools, so you have a comprehensive overview of machine QA aspects of your organization. Analytics, machine logs, and incident learning logs provide additional tracking and assessment tools needed to meet process improvement goals. Now, I've talked about a lot of devices. I'm sure you're asking yourself, what about patient QA? Of course, no stereotactic QA program is complete without the consideration of patient QA. So in that regards, I'd like to just say that we take a holistic approach to patient QA, making sure it doesn't end with just pre-treatment QA. Again, to repeat and emphasize, a few fractions delivered at high dose rates means that there really isn't any room for error. And I bring up these software solutions because I can't tell you the number of talks I have attended where physicists question whether patient QA devices that seem to pass over 98% of the plans, no matter how complex they are, whether that's actually giving them actionable data. It also just ends with pre-treatment QA. Are you doing QA to pass QA, or do you want to have insights into the treatment you are delivering? And I would argue that you really care about more insight into what's going on. So we provide an excellent pre-treatment QA solution with IamSure 3D using fast, independent Monte Carlo calculations, plus automated log file analysis for every treatment using LinAcView, which is monitoring machine delivery and checking plan complexity and more, plus automated in vivo patient QA with Adaptivo, which also has a pre-treatment and adaptive modules for expanded patient QA. Now, I'm not an expert on this one, but our lovely colleague and medical physicist, Vicki Howard, put together this nice workflow to show how our holistic approach integrates very well into your stereotactic QA, patient QA program. So during treatment, pre-treatment, we have our IamSure 3D. So you doing the usual. You have your pre-treatment check, your second check here with IamSure 3D. And during treatment, then you have LinAcView and Adaptivo doing their bit. Now, if IamSure 3D failed or Adaptivo's pre-treatment QA failed, of course, you're going to go back and to the dosimetry planning and try again. Next on this, we have, like I said, our automated Adaptivo QA assessment and automated LinAcView QA assessments going on. Adaptivo uses the portal imager for daily exit image tracking. It monitors beam delivery and patient position. The measured portal is compared to a predicted exit image. The measured portal is also compared to a reference portal image. Signed gamma analysis results are provided with automatic notification if deviation is detected. And of course, reports are generated. All this detailed information is provided by Adaptivo, ends up helping to determine one, if there's a setup issue, but also if there's change in patient anatomy, if it is time to re-CT for adaptive planning. So it again is an adaptive planning assessment tool. Linac View, on the other hand, allows you not only to keep tabs on the delivered fluents compared with the planned fluents, but also monitor your MLC leaves very closely. Also keep tabs on gantry angles, collimator settings, all in extremely fine detail and completely automated. Particularly, and most importantly, for SRS and SBRT patients, it monitors every single one of the patient treatment beams, so you know that your machine is operating properly. And again, it will automate alerts to you should that be required, or anything be out of tolerance, I should say. So that really is the end of what I had to present for you today. So I'm going to give you the opportunity to put in any questions that hopefully I can answer for you. And while I give you a moment to think about those, I do want to go here and just give you some further resources that we have available. Of course, we've got our website. If you have particular questions or want more information, you can reach out to sales@standardimaging.com. If you have any particular questions for me, based on the information I provided today, you can of course reach me at azens@standardimaging.com. I want you to know that we have a webinar coming up in a couple weeks that's going to focus on how you simplify SBRT and imaging QA with the newly released thorax phantom. And since I'm not a patient QA expert, because I'm not a physicist, I do want to point you to our recorded patient QA webinars for a lot more details on Adaptivo and Linac View, and I am sure 3D, how that holistic, comprehensive approach really gives you the tool, arms you with incredibly intelligent and automated tools. There are a couple recorded webinars on our website: the Elevate Patient Quality Throughout the Treatment Journey with Adaptivo, and also has TG307 Got You Thinking About EPIDs. That is a pretty hot topic we're hearing a lot about ourselves. You probably are as well. So that, oops, sugar, I lost it. I'm going to ask for the help of my dear colleague, Ashley, that's on the call, because I just lost my webinar stuff to see whether you have questions or not. Okay, here, there I go.
Gotcha.
Now,
I don't see any that have come through, so.
Okay. Well, if I haven't seen it, if we don't have any, or if you're like me and you think about it after you get off a call or get off this webinar, let me just say thank you very, very much to everyone who has attended today. I appreciate your attendance, and we look forward to seeing you on the next one. Have a great rest
Andrea,
of your day.
Looks like one came through, Andrea. Is there auto analysis software for Lucy EA?
So no, there is not an automated analysis software associated with Lucy EA. It is your point measurement with an ion chamber and then film analysis. And then for Winston Lutz, you would grab those using the EPID images, and those can be automatically analyzed either in our PIPS Pro software or in QA Pilot with PIPS Pro Autopilot. And I would just like to state, that QA Pilot has a lot of customization available in it, and we work with you to make sure that the SRS QA that you're machine QA you are performing is tracked in that software, so that you're really monitoring and have access to data that you can then use for, again, your process improvement type goals, or things that you want to really follow up on analytic wise. Are there
They're
any other
also
ones?
wondering, yeah, they're also wondering if PIPS Pro does multi-target Winston LUTs.
Not yet. That is something that is on our roadmap. So that is something that might be easier for you to track actually in PIPS Pro Autopilot in the QA Pilot platform for now. But like I said, that's on our roadmap for PIPS Pro. Any other questions? Okay, well, since I'm not hearing any from Ashley, I'm going to again say thank you, everybody. It was a pleasure. Have yourselves a great rest of your day wherever you are in the world, and we'll see you next time. Bye-bye.